Hey guys, it's Chris Noel again. Welcome to another lecture slash sim session slash workshop from Cooper Critical Care Medicine. Today we're going to talk about pulmonary artery catheterization, the procedure, how we go about interpreting everything, and actually go through a little bit of the history of the catheter and where we got to where we are today. So, I thought sim is a generic term, and in honor of Haney Malamet, to make it a little more exciting, thought we'd change the name to SimX. So that's what we'll go with from now on. So the basics of the procedure. So when we talk about a PA catheter, what we're talking about is a long catheter that we pass all the way from the SVC into the SVC, or if you're coming from the femoral, the IVC, into the right atrium, into the right ventricle, to the pulmonary artery, and then we essentially wedge, or we have this balloon which has already been up, gets stuck in a smaller artery in order to block off any information that's back behind the balloon, in order for the sensor that's here on the tip of the catheter to read pressures, waveforms in the pulmonary vasculature that is in communication with the left atrium. Now, the reason we do that is what essentially we're trying to get at is we're trying to get at the preload of the left ventricle. So we know that by the Starling curve, the higher the at least to a certain degree, the higher the end diastolic volume of the left ventricle, the higher the cardiac output. So we can't directly or indirectly with this catheter measure that volume. However, if we use pressure as a surrogate, then that's what the Swan-Ganz catheter helps us do by getting a pulmonary artery occlusion pressure. So it's saying, hey, what's the pressure in the pulmonary vein, which should be equal to the pressure in the left atrium, which should be equal to the diastolic filling pressure of the left ventricle. The other measurements we're getting from a PA catheter are threefold. One, we're getting pressure waveforms from all the way from the CVP, from the vena cava and right atrium, to the pulmonary artery. And then, like I said, we wedge off to get what is the pressure going on in the pulmonary vein and left atrium and left ventricle and diastole. We're also measuring the pump function of the heart, so we get a measurement of cardiac output and then can determine the cardiac index based on the patient's body surface area. And then we also can measure the SVO2, or the oxygen content of blood sampled right at the tip of our PA catheter, which represents the mixed venous blood from everything in the body. And this can give us an idea of the balance between the delivery of oxygen and the consumption of oxygen in the patient, and see how adequate or inadequate that is. So when we talk about measuring cardiac output through a Swan-Ganz catheter, the two main methods are thermodilution and the Fick calculation method. So when we're talking about thermodilution, the catheters, and there's different brands, you're either injecting cold saline through the catheter that then will float through the heart as the heart beats and make its way to the distal end of the catheter, so that at the distal end it measures the temperature of the blood that it sees. So as you might imagine, if you inject cold saline in the proximal end of that long catheter and it makes its way to the tip very quickly and washes out very quickly, that suggests that the cardiac output is very high. However, if it takes a while for that temperature to reach that the sensor and then washes out very slowly, that would suggest that the blood flows slower and the cardiac output is less. So what you see on the right-hand side is a graphical representation of what we're actually doing to try to determine that. So if we see this curve B here, this would represent our quote normal cardiac output curve. And so as we inject that cold saline, the temperature difference increases up to a certain peak and then falls off as all of that blood washes out. And what we're calculating is we're determining the area under the curve to get at what the cardiac output is. Now, if you imagine a very high cardiac output, that temperature differential is going to be reached much sooner and wash away much quicker. So that's going to be a smaller area under the curve, which corresponds to a higher cardiac output. And by the same logic, if you imagine a very low cardiac output, it's going to take a longer time to reach the peak temperature and a longer time for that cold temperature to wash out. So that's the low cardiac output is represented by C, or large area under the curve. Now, you can see here on as indicated by D, if you're using one of the catheters where you inject cold saline to get at the cardiac output, if someone were to inject it at an irregular speed, so let's say it's a 10 cc syringe and they inject 3 cc's very quickly and then inject the rest more slowly, then you're going to get this irregular shape of the slope of this line, and that suggests that the measurement is not very accurate and you shouldn't use it. The other method of determining cardiac output is the Fick method. So the Fick method uses the measurement we get from the distal end of the catheter, so the SVO2, the oxygen content of that blood there, and compares it to the oxygen content from an arterial line, plugs in the hemoglobin concentration and some assumptions about the patient's oxygen consumption, and you calculate ultimately what your cardiac output might be. Now, the two tend to correlate or can correlate well. Often you'll use both and just see how well they correlate for future measurements, but also just to get a general idea of what's going on. So you may have heard a lot about PA catheters. Some people love them, some people hate them. So why is that? What's the evidence behind them in the use in critically ill patients? So back in 1970, that's when Swan-Ganz published their first paper on the use, or the first paper of the use of the PA catheter in humans. And it was catheterization of the heart in man. Now the title was a little bit longer, but I felt like that was the meat of the title and essentially the paper. So after they had tested the catheter in dogs, they went ahead and used it in humans, and they talked about how it was about 300 seconds or so to get the catheter inserted and get a wedge pressure on the humans that they tested. So shortly after that, the product was commercialized, and the use of the PA catheter grew exponentially, and at one point it was being used in over 20% or more of critically ill patients to help to guide their management. Now, in 1987, what happened was that Gore and colleagues published an observational study of what mortality and length of stay were for patients with acute myocardial infarction who got managed with a PA catheter versus those who didn't. And what they found was that on their observational study was that there was higher mortality and length of stay when PA catheter was used versus not. And in the subgroup who had cardiogenic shock, there's really no difference. So based on this study, as well as a subsequent one by Zion et al., which found the same thing, people were worried that maybe PA catheters are not so good. Maybe they're actually dangerous. And so from this spurred a number of studies in the 1990s and early 2000s about the use of PA catheter, mainly in kind of the general critical care population as well as ARDS. And what they found was that really there was no significant benefit when you looked at the studies as a whole, but no real harm either. And most of the outcomes here were looking at mortality, benefit, length of stay, kind of end outcomes when we're, as we'll talk about in a minute, we're really looking at a monitoring technique and not a therapy. So, and then in 2005, a study you may have heard of is the Pac-Man trial, and I'll show a slide on it here, but it was a randomized trial of using PA catheters or not in a general critical care population. So, you know, some of the studies were in ARDS, as mentioned, no real difference in outcomes. And then the Pac-Man study, which I mentioned in 2005 in Lancet, this was a study where they took general ICU patients where the physician actually said, hey, I need a PA catheter. And at that point, the patient was randomized to getting a PA catheter or not. And there was no protocol after that based on, so if they got a PA catheter or not, that didn't determine what kind of treatment the patient would get. The physician just used the data or not in order to treat the patient. And they were allowed to use non-invasive monitoring techniques as well. So what they found was that there was no major difference in the primary outcome of in-hospital mortality, but also no increase in harm, which was the concern from the early studies. And just I thought was interesting, only 10% had decompensated heart failure. And as we'll mention again on another slide, and as I already mentioned, is it fair to judge a monitoring device by mortality as your primary outcome? So that's the Pac-Man trial. Based on all these trials, oh, and I should also mention, as we talked about, one of the ideas of the PA catheter is that when we use the measurements, we're trying to get at, hey, what's the filling pressure of the left ventricle? So if someone's in shock, if we then give them more fluid or we give them an inotrope, what's going to happen to their cardiac output? That's the whole idea behind it, right? So this graph says, hey, okay, we give them crystalloid, we're going to raise their filling pressure, and then as a result, their cardiac output is going to increase. And based on the patient's heart and their personal Starling curve then determines what happens. So at the same time that there was these studies questioning the benefit, there are also some studies which looked at, well, does the wedge pressure that we're measuring, the filling pressure of the left ventricle, does it even really get at what the change in cardiac output is going to be? And so I know this is a very busy slide, but I thought I would mention it because it's interesting, and two, it was done by some of the people you may recognize from Cooper. And what they did was they took healthy volunteers, and in one group they used a PA catheter and they made measurements before a 3-liter saline bolus and then afterwards. And then they determined, hey, did the wedge pressure measurements that we took, did they correlate at all with our change in cardiac output? And what you can see here is that on the bottom, this is the wedge, and here's our CVP, and they looked at CVP, and there was no, if you look at stroke volume index and stroke volume change, they did not find a correlation between what the pulmonary wedge pressure was or the CVP was in these measurements, which I think is interesting, and also kind of raised questions as to what is really the utility of the PA catheter. So as a result of all these studies, what you saw was that from a peak in the early 90s, we saw a gradual decline, or maybe a more precipitous decline in the use of the PA catheter. So much so that in 2013 and in some of the other early 2000s, people were publishing things like, hey, the obituary for the PA catheter. So Merrick published this in 2013, and he essentially talked about how other monitoring techniques are more useful, sparing certain conditions like right heart failure or pulmonary hypertension. There's also a Cochrane review of all these studies, the higher quality studies in 2018, looking at the outcomes of the use of PA catheter in critical care populations, so kind of a general critical care population as well as some sick surgical populations. And they looked at 13 studies, and I'll just read you their conclusions, which they highlight one of the things that we already mentioned, which is PAC is a diagnostic and hemodynamic monitoring tool, but not a therapeutic intervention. Our review concluded that the use of PA cath did not alter the mortality, general ICU or hospital length of stay, or cost for adult patients in the intensive care unit. The quality of evidence was high for mortality and length of stay, but low for cost analysis. Efficacy studies are needed to determine if there are optimal PAC-guided management protocols, which when applied to specific patient groups in ICU could result in benefits such as shock reversal, improved organ function, less vasopressor use. Newer, less invasive hemodynamic monitoring tools need to be validated against PAC prior to clinical use in critically ill patients. So essentially they're saying, hey, maybe it's not fair that we're measuring this monitoring tool on the basis of mortality and patient-centered outcomes when none of these studies really specify, hey, what do we actually do with the measurements that we've taken? So kind of where does that leave us in 2020? So I think some people will always hate the PA catheter, they deal with, and some people are going to absolutely love it. So I think, as for most things, the answer is probably in the middle. The PA catheter and its measurements are pieces of data, and they should be considered in the context of the overall clinical picture, echo findings, and other non-invasive monitoring techniques. And I'll say that it can be a very helpful tool in specific situations in particular. Those would be right heart failure, cardiogenic or undifferentiated shock in order to try to get at, hey, is there a cardiogenic component? Post-cardiac surgery patients, when you need to convince or communicate with colleagues who may want to know what the SWAN numbers are, and it may be difficult to convince them based on other pieces of information. And then 5, when you need real-time continuous cardiac output measurements in response to therapy. So I think this one's important. You know, echo and other techniques are great, and some of them are there where you can get continuous cardiac output measurements, but I think echo and some others may be more time intensive. So just think about that. If you need a real-time readout and you don't want to have to keep going back in the room, which we all are constrained with time, then this may be a good option for you. So, and ultimately, the procedure and its interpretation skills, regardless of what you think about it, are skills that we need to have as intensivists. So, let's talk about the procedure itself. So, important to know your equipment. So, there's various brands that make different PA catheters, but essentially they're all pretty much the same. And a lot of them will use the same color conventions too, which is helpful. So here I've shown a typical PA catheter, and what you see here is there is a balloon inflation port. So I mentioned that there's a balloon at the end of this catheter that one helps us with placement, but also helps us get that wedge so we can get the measurement of the distal to the balloon. So it includes a 1.5 cc syringe, which in most models you cannot pull back, or you cannot draw in more than 1.5 cc's of air as a safety measure so that you don't overinflate that balloon when it's wedged in a little pulmonary artery. There's also going to be often a thermistor port. So this is what is measuring the temperature changes when we were looking at that cardiac output curves. You'll have a proximal port, or a CVP port. This is usually in blue, and this will help us we can measure CVP. We can sometimes get at maybe some models, this may be where they prefer to give medications through, or in order to inject the cold saline. You'll have the distal port, which is often designated by yellow, which is at the very tip of that catheter, and where you're going to measure your PA pressures as you're inserting it, and also where you're going to be able to get your SVO2 sample from that tip as well. And then some Swan-Ganz catheters will have a designated port for fluids and medications that's extra from all of these other ones, which you're typically using to transduce pressures from. So this is one model of the Swan-Ganz catheter. You'll notice at Cooper we have a slightly different one, and these are all the ends of the one that we have at Cooper. What this Swan-Ganz catheter, and it's important to know, is this is the continuous cardiac output Swan-Ganz catheter. And so what differs, I apologize it's not in this picture, between the last one we saw, is that on this catheter, if we imagine this is our catheter, here's the balloon, here's the tip of it here, rather than injecting cold saline into the catheter and then detecting it further down the line, what it actually has is it has a coil, and you can see it, it's like a copper appearing coil on it that actually heats the blood up. And so it heats the blood up, the blood is washed down to the sensor, and then it's detected and it gets at the cardiac output by the same temperature change curve that we talked about before. But what's nice about this one is that you never, the nurse or physician or whomever doesn't never have to inject cold saline in order to get the measurement. So it's every so often automatically heating up that coil so you can get a continuous cardiac output measurement. So that's why, in contrast to the catheter we saw on the other slide, there's actually two different ports, one for the heating filament and then one for the sensor that actually measures the change in temperature. Otherwise, similar things. We see the yellow PA distal lumen catheter. We see the proximal injectate port, CVP, which is blue, and we see the red balloon catheter. This one also has continuous oximetry cable, so it actually detects the SVO2 continuously at the end here, so you don't have to draw any blood back, which is also a nice thing and allows for that continuous cardiac output monitoring. So very cool. This is the one we actually carry both at Cooper. This would be the preferred one to use because you can have those measurements all the time. It's less work intensive and nice to know those numbers. So what about the contraindications to the procedure? So most contraindications that you may read about are relative. Just two to mention would be infection at the insertion site, just like any central line, and then right ventricular assist device, which you probably can't pass that catheter, or at least it would get chewed up and stuck in the right ventricular assist device, which would be very bad. There are some relative contraindications that you should know about, so be careful with a pre-existing left bundle branch block or even right bundle branch block for that matter, because as you pass your PA catheter, you can cause a transient right bundle branch block, which may not be so transient in the left bundle because you can cause asystole. So be aware of that. Be prepared to deal with that if that were to happen. It is rare, but not unknown, and so just know about that. Also, be careful with severe pulmonary hypertension and coagulopathy. The reason I mention these is the most feared and very rare, but luckily very rare complication of a pulmonary catheter placement is pulmonary artery rupture, and this often happens when either the balloon is over wedged, meaning it's pushed too far down into a little artery or arterial, and or it migrated too far and you blow up that balloon and it's too much pressure and it ruptures, and the patient almost invariably can die from that. So severe pulmonary hypertension, the blood vessels are more fragile and that pressure is higher already, so you're more at risk. Now, in terms of when we're putting the catheter in, how do we know where we are and in space, because we're not seeing this in real time through the heart? We're going to be looking at our monitor. So when we insert our PA catheter, we're going to get continuous pressure readings from the distal end of that catheter. So on the monitor, this should be hooked up and zeroed on the monitor, and we should start seeing a pressure tracing that is the CVP tracing. Once we see that on the monitor, it's time to go ahead and blow up this balloon. So it would be with that 1.5 cc syringe. We blow up the balloon once we see the CVP tracing, and then we can continue to advance the catheter into the right atrium and so forth. So we'll go through the exact waveforms in just a minute, but note that the CVP tracing, you'll see this undulating pattern with several waveforms that we'll talk about. So if you see that, so initially you're inserting with the balloon down. Once you see this waveform, you can go ahead and inflate the balloon. Some people also talk about, if you get to 10, 20 centimeters, that's the time to inflate the balloon, but probably the safest way to do it so that you're not too proximal and in the catheter, or you're not too distal, would be to look for your CVP tracing before you blow up the balloon. So from here forth, that balloon is going to be inflated. So you're going to then advance from the right atrium into the right ventricle. You're going to see a change in your pressure waveform tracing. And as you further advance into the PA catheter, you're then going to see another change. And you'll notice here we see a step up in our diastolic pressure. We also see a dichrotic notch similar to our A line once we get into the PA. If we're going to wedge the catheter, we're going to keep going. And again, once it wedges, what you're going to see is transition from that RV tracing to this, or excuse me, not RV, excuse me, the PA tracing with the dichrotic notch to this small undulating pressure, which usually is at the level of the diastolic pressure of the PA, which is our pulmonary artery wedge pressure. And it also looks, as you may have already picked up, very similar to the CVP tracing, and we'll go through the waveforms in just a minute. Now, what if you see this tracing? So let's say at this point here, we're either advancing through the PA, so this is our PA pressure tracing, right? We see the dichrotic notch. We see a nice, it looks like an A-line, right? So if we see this pressure tracing and either we keep advancing that catheter and all of a sudden we see the pressure go through the roof, or let's say we've already placed our PA catheter and then at this arrow here, and the balloon is down. We've already placed it. The balloon's down. The patient's chilling. We reinflate the balloon and we see this pressure tracing go like that. What does that mean? So essentially what that is this is what you see when you're over wedged. This is not good. The pressure reading is going very high, and this is where you get into danger of you can have that feared complication of the pulmonary artery rupture. So if you see this, deflate the balloon and come back. Now, why is it rising like this? So you may have seen a subtle change in the animation that I had, but if you imagine over here, let's say we have our artery here, right? So the pulmonary artery. And normally when we inflate that balloon, it's a nice sphere. It takes it up perfectly. It's wedged, and then we get our measurements at the distal tip here. Well, let's say we advanced it further down, and it's a much smaller arterial at this point. So now, if we inflate that same balloon that's indicated here in this little artery, what's going to happen is it can't expand to that nice sphere. Sorry, guys. What it's gonna do is gonna become oblong, like an ellipsoid, and then actually what it can do is it can occlude the distal tip of the catheter, and or push it against the sidewall, and you'll get this very steep rise in the pressure. So this is very bad. If you continue to inflate the balloon, it can rupture that artery. So this is what over wedging looks like. It's very important to recognize. All right. So just to summarize, we talked about when you go through the superior vena cava into the right atrium, we're going to get our nice CVP tracing. We're then going to pass into the right ventricle. We're going to get something that looks almost like an electrical VTAC, and you may see PVCs when you do this. When you get into the pulmonary artery, as you advance further, you're going to get a diastolic step up. So see the diastolic pressure here. It steps up in the PA. And then you also see the appearance of a dichrotic notch in the PA tracing. And then finally, once you've wedged once you've wedged that balloon, you're again going to see a tracing that looks very similar to CVP. It'll usually about the level of where the diastolic pressure was in the PA. So, and this is just an animation. I hope it plays of of what we just saw. Let's see. Yeah, there it goes. So again, we inflated the catheter, the balloon's down. Okay, now we see our CVP tracing. We inflate the balloon. We start seeing our CVP tracing over here. We pass through the tricuspid valve. Now we start seeing the right ventricular pressure tracing. We pass into the PA. We see it change again. We see that diastolic step up, and we see that dichrotic notch. And now the balloon's going to get wedged, and we're going to start to see that undulating pattern. So here they just deflated the balloon. So if you deflate the balloon, you're going to see the PA pressures again. They drew back, they reinflated, and they re-wedged, and you see the wedge pressure again. Now they're deflating the balloon as we would normally do to maintain it, and you see the PA pressure tracing again. So this is just a animation of the thermal element. So we talked about the one at Cooper has a thermal element, so it heats up the blood. Okay, intermittently heat up the blood, and then at the distal end where this white line is, it's starting to detect the temperature. and over time it can graph it and get an area under the curve to get at what the cardiac output is. And since this is heating itself up based on a time, then you can get a continuous cardiac output monitoring. So every 30 seconds or something, it'll update. All right. So once we've placed our PA catheter, we're going to get an x-ray to see where it is. Apologize for the low quality of these images, but luckily we have the black arrows which can help guide us, and I have this great pen so I can draw where the catheter is going. But in the top upper left here, we have what is a reasonably placed PA catheter. So you see it coming down through our central line, it's curling through the RV and into the PA, and the distal tip is in one of the PAs. Which is great. On the top right, we have an example of a PA catheter that is too distal. So it's coming up, going through the PA, and then it's far out in the periphery. And generally what we're looking for is we want to see the distance from the center to that tip to be less than 5 centimeters. So anything more than that, we're too distal. We could be in a small artery and we're at risk if we blew up that balloon, that would be too high of a pressure. But also that the catheter itself could occlude that vessel when the balloon is not inflated, and you can lead to things like pulmonary infarct. On the bottom left, we have an example of a PA catheter that is very much looped in the right ventricle. So this can happen if you continue to advance your PA catheter because you haven't seen your PA pressure tracing, and you don't keep track of your measurements on the PA catheter, and you've gone in, let's say you've gone in 70 centimeters and you still haven't seen the PA tracing, then what can happen is this catheter can actually get looped up in itself, and it can get tied in a knot, and that's a big deal. So always keep an eye on where you are distance-wise. If you're 50 centimeters and you haven't seen a PA pressure tracing, think seriously about deflating that balloon, retracting the catheter, and starting over, because it's likely that you're just looping around in that RV. And then finally, in the bottom right, we see the distal end of our PA catheter is not in an appropriate position. It actually went down through into the IVC and then is in one of the hepatic veins. So not ideal either. All right, so we talked a little bit about, or at least we visualized the waveforms. What are the components of them and why did they happen? So when we talked about in the right atrium or in the superior vena cava, we're going to see our CVP tracing. And what you'll notice is there's 3 positive deflections in the ideal wave, and there'll be 3 dips, or 2 essentially dips in the waves. So you'll see, and I apologize for the small font, maybe low quality of this, but there's an A wave. And what the A wave represents, that's our positive deflection, it represents atrial contraction. So if you imagine the atrium contracting here, you're going to see some back pressure, and so that's going to be a positive spike, and it occurs after the P wave. Okay. The next wave you're going to see is going to be your X descent. So as that atrium empties after the atrial kick, blood is ejected into the ventricle, and that pressure is going to fall at the X descent. So as the ventricle starts to contract, the tricuspid valve closes, and the tricuspid annulus kind of pops up just a little bit, and you get a positive pressure deflection, the C wave here. As the ventricle continues to contract, it moves downwards and inwards. Then what happens is you're going to see another fall in the pressure up until a point where the atrium fills up with blood, ventricular systole is happening, atrial diastole is happening, the pressure reaches a peak, and you see a V wave here. Once the pressures reach the point where diastole occurs and that tricuspid valve opens, you again see another fall in the pressure via the Y descent. So just to reiterate, the 2 main waves you care about are the A and the V are the most prominent ones. You may also see a C. The A wave happens in corresponding to atrial contraction, so it should correspond to just after the P wave. And then the V wave corresponds to ventricular systole, which is also atrial diastole. and that should correspond around after ventricular or after after the electrical activity that causes ventricular systole. So A and V are the positive deflections, X and Y are the negative. You may also see a C wave, which corresponds to that tricuspid annulus bowing upwards as ventricular systole starts. As you move the catheter further along, and again, the balloon is inflated this entire time, you're going to enter the RV. You're going to see this big swinging pressure, and you're going to see that what that corresponds to is the peak pressure is the isovolemic contraction of the right ventricle. Pressure is very high, and then as that ventricle relaxes in isovolemic relaxation, you actually may see negative pressures because it's about to suck blood in through the tricuspid valve. As you advance further into the pulmonary artery, you're going to get a diastolic step up, so from here all the way up to here. And the other thing you're going to notice is you're going to start seeing these dicrotic notch, and that corresponds to the pulmonic valve closure. It's the analogous to the dicrotic notch you see on an arterial tracing from an A line, which that corresponds to the aortic valve closing. As you continue to advance, eventually you're going to wedge the catheter, and so from that PA systolic pressure tracing here, you're going to then see a small undulating waveform, which, if you remember the CVP, it looks exactly the same. Why is that? The reason is because when we are measuring our CVP in right atrium, it's measuring what's going on here and in here, right? Well, if we wedge, then we block off everything here, so we don't see any of these pressure tracings, and all we see is the pressure from the pulmonary vein in the right atrium. So it should look the same as the CVP, but the pressures are originating from the left atrium rather than the right. Now, in reality, you don't really see the C wave on the pulmonary wedge pressure tracing. So you're really just going to see an A wave, an X descent, V wave, and the Y descent. And again, the A wave corresponds to atrial contraction. The X wave, X descent, corresponds to atrial emptying and then refilling. And then V wave is as that ventricle contracts, the atrium fills up to a maximum pressure, and then it empties again in diastole at the Y descent. Same text we just talked about, just saying that, hey, it's all from the left atrium, not from the right as the CVP. So when you're looking at the Q or S, so on the monitor, you're going to see your EKG leads and you're going to see your pressure tracings. So easiest to start here at the right atrial or CVP tracing. So we talked about the A wave corresponding to atrial contraction, the atrial kick. So it's going to occur after that P wave. The V wave is going to correspond to after electrical activity that initiates ventricular systole. So the V wave is going to be somewhere around the TP segment. The same thing occurs in the pulmonary artery wedge pressure, but as we talked about, rather than being, if we talk about the SVC here in the right atrium, and our pressure transducer is right here, and seeing everything that's happening in pretty much real time, when we're all the way up in the, let's see, there's a ventricle here, when we're already all the way up in our pulmonary artery, and then in our, when we've wedged out here, there's a long distance all the way to get to the left atrium. So you're going to see a time delay, as you see here, between the A wave and the P wave up here, and you're going to see a time delay between the electrical activity causing systole and your V wave here. So how do you know which wave is which? A wave is going to come after the P wave. When you're looking at a pulmonary artery wedge pressure tracing, generally if you just draw a line down from your Q or S, the wave that it hits is going to be your A wave. The V wave is going to occur during the TP segment, but if you can determine the A wave, then it should be the next one. But yes, V wave during the TP segment, it will happen before, see how it peaks before the next P wave. All right, so here's some examples of determining which wave is which. So if we look at this first box here, these two waves here and here, if we look at where the P wave is, we see that the P wave starts after, or this wave starts before the P wave. So if the P wave corresponds to atrial contraction, atrial kick, then this wave cannot be the A wave. It must be the V wave. Then by deduction, so that we say this must be the V wave, then by deduction, this must be the A wave. And again, we see, remember we said draw a line down from the QRS and you're going to hit the A wave. So that's what we're seeing. And V wave corresponds to the TP segment, the V wave, and so forth. And there we are. So let's try another example. This one's a little bit easier to see. Again, we see our P wave here. The A wave happens after the P wave, and in the pulmonary artery wedge pressure tracing, if you just draw a line down from the QRS, I'm sorry about that, then you should hit the A wave. So let's see what that is. Yep, A. And then the V wave corresponds to the TP segment, the V. And remember I said we're not really going to see the C wave in the pulmonary artery wedge pressure tracing, so forget about that, but we will see it in the CVP. All right, and then at the bottom right we have another example. Now you'll notice that the waves look very different from the other examples. There's one of them that's much larger, and we'll talk about why that is in just a second. But if we use our same method, we see our P wave here. The wave that happens, remember this wave starts before the P wave, so it can't be the A wave. The one that starts after the P wave is here, so that must be the A wave. And again, if we drew a line down from the QRS, we're going to see that's our A wave. And here, that by deduction, this must be our V wave. And again, we drew a line from the TP segment and we hit our V wave. And let's see if that's correct. It is. Great. Now, we'll talk about in the next slide, why is that V wave so big? And if we think about this corresponding to ventricular systole, what's going to make that pressure huge is if there is a leak in that mitral valve so that pressure can push backwards from the ventricle. So this is a large V wave of mitral regurgitation. So just one more example. So this wave here, it happens after, hard to see the P wave, but if we drew a line down from the QRS, it's got to be our A. We drew a line from the TP segment, it's got to be our V. And indeed it is. Okay. All right, so how do we know when to measure our wedge pressure? So this is important. When you have someone who's spontaneously breathing, so you're going to see an undulating pattern of the wedge if someone's breathing on a vent or someone's breathing spontaneously. But how do we know at which point to measure it? We need to know about if they're on a vent or not. And in any case, as we mentioned at the top of the slide, we're always going to measure our wedge pressure at end expiration. So if we imagine someone who's spontaneously breathing, right, they inhale, there's a negative pressure in the chest. So the pressure in inhalation when someone's spontaneously breathing is going to be the lowest during inspiration. So let's say this guy is spontaneously breathing. This has to be our inspiration because it's a negative pressure. And as we breathe, as we exhale, we return pressure to atmospheric, and so this must be exhalation. It's going to be higher pressure. So if we measure at end expiration, we have to measure our wedge right about there. And there we go. Our wedge is 10. Now, if someone is if someone's on the ventilator, so then the whole thing reverses. Because when we have inhalation, we're using positive pressure ventilation, so the pressure is going to be higher. So this would be, if we have someone on the vent, then this is going to be inhalation. And then as they breathe out, the pressure gets less. So this has to be exhalation. And so we'd measure our wedge down here for someone who's on the ventilator. Now, an easy way you can remember that is vent equals valley to know that's where you measure your wedge pressure when someone's on a vent versus the other way around when someone is not ventilated. Now, why do we measure it during end expiration? If you imagine, if you tried to get at the same pressure for someone who's spontaneously breathing and vented, the only real difference, major difference, is the inspiratory phase. In spontaneously breathing, it's negative pressure. In vented patients, positive pressure. But exhalation should be fairly equal. You know, there's PEEP and stuff, but that should be equal. So that's where we measure our wedge pressure. The other thing is, the respiratory cycle is predominantly made up of the exhalation phase. So that's actually longer. So it's probably easier to get a measurement at that time. All right, another thing to note is when you see the tracing on the monitor, whoever is managing the monitor actually has to, so it'll show up this line, computer displays a line, and you actually have to adjust where it needs to go in order to get the measurement of the wedge. So if you just left it where it would just say 10, which we can see that the wedge tracing is up and down, and that's not accurate. It's not an end expiration. So in this patient who, this one is going to be spontaneously breathing, then we need to actually move that line up to here in order to measure our wedge, which comes out to be 18 rather than 10 if we had not moved the line. So that's important because you may see a pathologic wedge versus what would have been read as a normal wedge otherwise. Okay, other parameters. So SpO2 and cardiac output. So remember, SpO2 is going to be detected from the distal PA port. Normal value, roughly 60 to 80%. Low values are going to happen when the supply is too low and the demand is too high. And you're gonna extract as much oxygen as you can. And high values when you have a high flow state or poor extraction. So the classic would be sepsis. That blood is pumping through, but the mitochondria can't work. It's not extracting oxygen. Excuse me. So the SpO2 would be high in that state. And then cardiac index, you know, certainly less than 2.2 is low. And go from there. So what are some pitfalls in these measurements? So you may hear about west zones of the lung. So when we are sorry, going out of order here. So we talked about when we measure we measure the pulmonary artery wedge pressure. It's going to be when we are at end expiration, vent equals valley. Another pitfall is that we are not accounting for PEEP. So if you have a PEEP less than 10, the wedge is not going to be that significantly affected, but if the PEEP is greater than 10, keep that in mind. You may see an increase in your wedge by roughly 2 to 3 for every 5 above 10. And then finally, we talk about west zones of the lung. So if you have a PA catheter tip that's not in zone 3, then your wedge tracing, your wedge pressure that you're getting may not be entirely accurate. What is west zone 3? It's below the tip. The tip is below the left atrium, and the reason that the measurements are most accurate there is the zones correspond to the relative pressures. Which one is the highest between the pulmonary artery, the alveoli, and the pulmonary vein? And in zone 3, the artery is greater than the vein, which is greater than the alveoli. Whereas up at the top, you have alveoli beats everything out. So if you tried to measure a wedge pressure up in zone 1, then the alveolar pressure is going to be what you see the tracing of, not really the wedge pressure. Whereas in zone 3, artery beats out everything else, so you should have a more accurate measurement of what that wedge actually is. Now, are you going to ensure that it's in west zone 3? Only about 30% or so of PA catheter tips end up there, but it's something to keep in mind if it's not making sense. And I should mention the way that you would know if you're in west zone 3 is if you were to get a lateral chest x-ray, and you could see the placement there. All right, so what about thermodilution? There are two major conditions which you'd get, sure there are others, but two major ones where your thermodilution readings may not be as accurate as they could be. So number one is going to be tricuspid regurgitation. So if you think for a second, would it lead to underestimation or overestimation of the cardiac output? So because the tricuspid regurg, that blood is regurgitating backwards through the tricuspid valve, it's going to end up taking longer for that cold saline or that filament heated blood to wash out through the system and away from that and the detector. So a longer time to peak temperature, longer time for it to wash out, that's going to look like a poor cardiac output. So you're going to underestimate your cardiac output with tricuspid regurgitation. Now what about shunting? So both right and left to right intracardiac shunts actually will lead to the opposite problem. The reason that is in a right to left shunt, if that cold blood gets injected, it shoots from the right side to the left side and dilutes very quickly. So it looks like the cardiac output's very high. And then if you have a left to right shunt, say you have that cold saline injected, that left blood is very warm. It shoots across and it heats it up very quickly. So again, it looks like the blood washed out very quickly and it looks like a very high cardiac output. So both shunts lead to an overestimation of cardiac output. All right, so let's talk about some pathologies. One thing to keep in mind when you're floating the PCath is what are your normal pressures, because as you float this, you're going to be recording the pressures that you get from the CVP/right atrium, the right ventricle, the pulmonary artery, and then the wedge if you wedge the catheter. So this one I steal from, I didn't hear it directly from him, but I've heard it from some of the fellows that Ed Gray teaches about this, and I think it's a great analogy, which is in the superior vena cava, the high normal pressure is going to be a nickel, 5. Same with in the right atrium, it's going to be a dime, 10. The right ventricle is going to be 25 or a quarter. Same with the pulmonary artery. And then when you wedge, just split the difference, about 12 with a high level of normal. And if you look at different references, they display slightly different numbers, but as a whole, this is a good way to remember it. So for those Canadians in our group, I think now we just have one Canadian fellow, but we definitely have some Canadian attendings. I tried to do the same with Canadian coins, but I'm sorry, they all look the same. It doesn't really work. So so we'll stick with the U.S. coin. Oh, sorry guys. So these are just some simple examples of what we would see when we have an obstruction in various parts of the vasculature. So if we have a swan in and we have, let's say we have a coarctation of the aorta, or we have critical aortic stenosis, what would happen with our wedge? And what would happen with our CVP value? So because we have backup, the pressure is trying to get through, but it can't. You're going to have backup of pressure to our wedge and also to our CVP. So our wedge is going to be high. Our CVP is going to be high. Okay, so let's say instead of here, we actually occluded the, let's say we had an obstruction of the really small arterial. So that would look just like primary pulmonary hypertension. So would our wedge be high, low, normal? CVP, same thing. So the wedge would be, lower normal, right? So wedge didn't get affected because it's distal to that. And then I guess the graphical representation isn't that good. So let's say it's the obstruction's here and we're wedging down here. So that's why the wedge would be normal. And then the CVP, maybe high as pressure backs up into the CVP. So let's say we had tricuspid stenosis. So our CVP would be very high, right? Our pulmonary artery pressure would be normal, and our wedge would be normal because the limitation is way back here. All right, let's say we had mitral stenosis. So there we'd have a wedge that is high. We'd have PA pressures, which are high. We have CVP, which is high, because it all backs up. Just like when we saw the critical aortic stenosis or coarc, same phenomena. So very simple examples, but I think it's just helpful to look at, and think about what's the physiology where is the lesion. All right, so let's talk about tamponade. So the classic teaching in tamponade, if you have a PA catheter in place, is that you get equalization of pressures, right? Well, which pressures are those? So they're the filling pressures. But what does that really mean? The filling pressures refer to the filling of the right atrium and then subsequently the diastole of the right ventricle, as well as the filling of the left atrium, or the diastolic filling pressure of the left ventricle. Now, why do these two equal each other? So the reason is when you get blood around the heart, that pericardium is going to restrict the filling of both ventricles, and you get equalization of those filling pressures because they can't fill anymore. That's limited by the pericardial fluid. And so the limitation of everything is not the systolic function of the right ventricle or the left ventricle, it's getting blood into both of those. And so if the pericardial pressure is the same throughout, then the filling pressures, or your pulmonary wedge pressure and your CVP, are going to be the same. So, all right, some other classic exercises. So if you have classic cardiogenic shock, cardiac output going to be high, low, normal, SpO2, CVP, pulmonary capillary wedge pressure, SVR. So cardiogenic shock, easy one is cardiac output, it's going to be low. SvO2 is going to be low because we're going to extract all that oxygen that we can because there's not much pumping through. CVP is going to be high, pulmonary capillary wedge pressure is going to be high, SVR is going to be high. So this is a classic left ventricle cardiogenic shock. So classic septic shock, though we see different states of this, and we all know cases of septic cardiomyopathy. Let's say the heart is doing just fine, it's actually hyperdynamic, then our cardiac output is going to be high, SvO2 is going to be high because we can't extract oxygen, it's moving through very quickly. CVP, say their vasodilated out, their CVP is going to be low, pulmonary capillary wedge pressure is going to be low, and their SVR is going to be very low. I'm sorry, SVR is systemic vascular resistance. It's calculated based on the other measurements from the SWAN. And then hypovolemic shock, also important to think about. So our cardiac output is going to be high. It's trying to pump as much as it can. Our SvO2 is going to be low because we're trying to extract all the oxygen we can. Our CVP is going to be low. Our pulmonary capillary wedge pressure is going to be low, and our SVR is going to be high. We're clamped down. We're trying to preserve all the volume we can that's in our body and get it to our vital organs. All right, so some examples of waveforms. So let's think back. So we talked about the two main positive waves are going to be the A and the V wave. So if we remember that the A wave corresponds to atrial contraction, then the A wave should happen after the P wave, right? And then, sorry, I should say that this is our pulmonary capillary wedge pressure tracing we're looking at. So if the P wave happens and then the next positive wave is going to be our A wave, and if we say, oh, if we just draw down from the QRS, it's going to hit the A wave, then hey, this must be the A wave. And then we say either by deduction, this must be the V wave, or we say, hey, it's somewhere along the TP segment that we see the V wave, so we draw a line down from there, we see the V wave, we get it. Oh, sorry guys, apologize that went away, but essentially the A wave on this picture was small, right, and the V wave was very big. We already talked about this a little bit, so remember the V wave is ventricular systole. If the V wave is huge, that means that something is causing back pressure during systole. The only thing that really does that is typically going to be your mitral regurgitation. So these are the large V waves of mitral regurg. All right, so another example here. So this is actually the same pathology, but it shows an example of the difference between the PA tracing and a wedge tracing. And so as you can imagine, if that V wave is huge, it may be hard to tell, am I in the PA or am I actually wedged? Because the V wave is so big, it looks like that systolic pressure in the pulmonary artery. So how do we tell the difference? So there's two ways to tell the difference. One, or I guess in this patient, one major way, but essentially what you're going to see is you're going to see a systolic waveform here, a notch, and then you're going to see that big V wave, right? So you see both waves here, but when you wedge, you just see that one big V wave. So this is important because if you, and nowadays with echo and everything, we can kind of go into our PA knowing that, hey, the patient has florid mitral regurg, because we've already probably put the probe on and seen that. Then we know that when we get to the wedge, we're going to see these huge V waves. Then we can keep this in mind and say, okay, we're in the PA, we see this bifid wave. When I get to the wedge, it's going to go away. It's going to be one single wave. And just keep it in mind too, if you're not sure, just think, hey, I could be already wedged because of V waves so big. So I think it's a good example. This is mitral regurgitation, huge V waves differentiating between the PA tracing and the wedge. And there you go. The S wave they're labeling here is the systolic wave versus the V wave, which is from the mitral regurg. All right, then another one here. So what is this? This is a PVC, right? So PVC, when a PVC happens, the ventricle contracts at a random time. So it could be that the ventricle contracts as the atrium's already contracting too. And so that mitral valve is closed when it should be open when that atrium contracts. And if the atrium contracts against a closed mitral valve, then you might get then you can get what we call a Canon A wave. And I know you'll say, oh, well, where's the P? It's probably lost. It's lost somewhere in here. That's why you don't really see it and can't use our typical approach. But just, I think it's a good example of the physiology. If you think about it, the atrium's contracting against a closed valve, you're going to get a Canon A wave, a very large A wave. And again, I guess it went away. That's okay. This I thought was just an interesting slide that I came across in one of the papers where they talk about a pulmonary reflection wave in pulmonary hypertension. So you may, for those of you guys who are studying echo and thinking about our pulse wave Doppler in the pulmonary artery, you may know that if you see the W sign in the pulmonary artery pulse wave Doppler, that means pulmonary hypertension. So this paper was talking about, you see the same phenomena as a pressure waveform in your PA pressure. And if you have pulmonary hypertension, you're going to see this reflection wave is what they call it. And what they differentiated was between primary pulmonary hypertension, where you have distal narrowing, versus chronic pulmonary thromboembolism, where you have more proximal narrowing or obstruction. And so because this is more proximal, you're going to see this reflection wave earlier, where if it's more distal, you see it later on. So I just thought that was a cool example of physiology and tying it in to what we're seeing on echo. So what are some, quickly, what are some complications? So note that you may have some cardiac arrhythmias. These are usually transient as you're placing the PA catheter. If you see them, don't futz around, just keep going. And they should pass as you get into the PA. But keep in mind, if you have right bundle branch block, remember, you can cause a right bundle branch block. So if you have left bundle branch block, you can precipitate complete heart block. So be aware of that and know that as a potential complication. Be prepared should it occur if you need to do the procedure. Mechanical complications. So the feared one is PA rupture, very low incidence. It's less than 0.25% described in the literature. It's like less than 0.1%. But essentially, it's what happens is if one of those fragile arteries ruptures, either from over-wedging or let's say you inflate the balloon against force, which causes over-wedging, then that artery may rupture. Usually it presents with sudden hemoptysis, and then the patient precipitously dies. Although it can be rescued by emergent surgeries, but it's a very bad outcome usually. So knotting. So this is important to know. So if you're pushing that PA catheter in, you're floating it, and you're getting to 50 centimeters or so, and you don't see a PA waveform, you're likely just coiling in that RV, And so if you continue to advance, you can actually knot the catheter on itself, and then you will not be able to remove it unless you have someone else intervene with either endovascular or open cardiac surgery to remove it. So if you get to 50 centimeters and you don't see the PA waveform, as a general rule, I would deflate, retract, and then try to refloat. Thrombosis, so pulmonary infarct can happen. So remember, don't advance beyond 5 centimeters on the midline on the chest X-ray, and then infection as any other central line. All right, so what are the takeaways? We covered a lot of ground. So remember, PA catheter is a tool. It won't save the patient, but it can help you. Just like an A-line doesn't save anyone, but it's very nice to have to know what you're doing with your therapies. Consider, as we saw, the evidence doesn't bear out to use it in everyone. It has risks, that's why we don't, but consider it in patients with right heart failure or severe pulmonary hypertension, cardiogenic or undifferentiated shock, post-cardiac surgery. When you need to convince colleagues, some people may really want to know what the right heart cath numbers are in order to do something or help you. And when you need a real-time continuous cardiac output measurements in response to therapy, it can be kind of a set it and forget it. So if you put it in and you have measurements which you feel confident about, then you can see what happens with your therapies and not have to keep revisiting some labor-intensive measurement. And then if you don't see PA tracing at 50 centimeters, remember, retract and refloat to avoid tangling that in the RV and knotting it up. Don't inflate the balloon if you already see a wedge tracing. So remember, if you already see a wedge tracing, don't inflate the balloon. You could over wedge and cause the feared complication of PA rupture. Never force inflation. And also keep this in mind. If you inflate the balloon partially and you see a wedge tracing, you don't need to keep inflating the balloon. You've already wedged. So at that point, I would say let it deflate, come back out, inflate the balloon, and then you can re-advance as the balloon's inflated to wedge, because that's probably the safest thing to do, is to not overinflate and cause further issues. Because remember, that catheter can sometimes migrate as it's just sitting in the patient with that balloon deflated, and so be cautious of that if you're going to go re-wedge a patient. And then finally, measure pulmonary capillary wedge pressure at end expiration. That's when pressures are relatively equal between a spontaneously breathing patient and a mechanically ventilated patient. Here's some of my references. Email me if you want some more. There's some great papers and great videos out there which helped me and could help you too. So thank you guys for listening. I hope it was helpful, and more to come soon.